Really, really, really big welcome to everybody. Thank you so much. So this is our Global Coalition for Radiotherapy World Cancer Day event. And obviously with the UICC, this is around closing the care gap through global collaboration, which of course is what we're all about. So we really appreciate you joining. We've had 150 people sign up already. We are recording this and sending this out. So if we just have the next slide to put the context in for us. So as we know, so introducing myself, so obviously I'm Pat Price. I'm co-founder of the Global Coalition for Radiotherapy, and we have the team here with us. So as we know, IARC just released the latest cancer estimates, and global cancer cases are predicted to rise by more than 75% by 2050. So that's more than 35 million new cancer cases. We know way back in 2022, 2 years ago, there was an estimated 20 million new cancer cases and 9.7 million deaths. And the estimated number of people who were alive within 5 years following a cancer diagnosis was 53 million. So obviously a disparity between countries. We know about 1 in 5 people develop cancer in their lifetime, and that's 1 in 10 men and 1 in 12 women. And higher income countries, it's even higher than that. So it's just putting in context the state of the problem and that it's an increasing problem. So if we have the next slide, Darian, thanks. Okay, so just a few housekeepings. This is our agenda today. So perhaps if you could use the chat to introduce yourselves, and we are recording this. And
any starting the webinar, Global Coalition for Radiotherapy webinar.
If we perhaps if we could all mute, yes, okay. As we do. That's okay. But as I say, use the chat box to introduce yourselves, and if you want to raise any questions, we've got people picking that up and feeding it through to the agenda, to the speakers. Now, as you can see for agenda, we've got a really exciting agenda now that we're going to get through. We'll try and keep to time. So we're going to go really through the situation, our essentials document, what we're doing together as a group, and then how we can implement things. But first, one of our star speakers today is Will, who needs no introduction. He's the director of the Global Health Catalyst, a fantastic radiation oncologist, well known throughout the world, has a faculty appointment at Harvard and Johns Hopkins, and as you can see there, founder of the Global Oncology, then chairs the Lancet Oncology Commission on Sub-Saharan Africa, and he's involved in the USA Moonshot, and he's the Oncology Commission leadership there. So we'll fire away. We're so looking forward to hearing you. Thank you for taking the time with us today.
Right. Thank you so much, Pat, for that introduction. Yeah, it's truly wonderful to be able to celebrate World Cancer Day together at a really critical time, as it's showing those statistics. We come at a time when the World Health Organization just updated the report that, you know, by 2050, we'll have about 35 million new cases a year. This is truly stunning and really should get everybody off the sidelines if anybody is on the sidelines. And as you know, the White House just released this hashtag, Global Cancer Moonshot, really to kind of highlight the need to extend the cancer moonshot globally. When President Biden first launched the Cancer Moonshot, obviously, one of the things that we did was that we went and said, okay, you need to think bigger. We talk about the Cancer Moonshot, we know it's big, but you need to think a little bigger. And by bigger, we meant that, you know, you need to extend that beyond the United States, you know, and really you can establish win-win collaborations that way. But here's the challenge. I mean, Pat just shared about those statistics, but closing the cancer care gap really means that we want to start to look at just a picture of what the disparities look like. A couple of years ago, actually a few years ago, I think 2017, the BBC published this article, which was that do US docs have better access to radiotherapy than Nigerian people? You know, it was sadly, you know, a provocative question, but sadly the answer is yes. And that really, you can look on the map on the right, which is an old map, but it still captures the situation today, you know, from the IAEA. You look at all the red, you know, you see the disparities in access to care. A lot of those countries in red do not have access to radiotherapy. And this is really, you know, a situation that needs to be addressed, because if you're born there of no fault of your own, you have no access to care. You have cancer, you're going to die a painful and distressful death. Another challenge, you just kind of get the snapshot of this. Obviously, there's a huge need for capacity building. And I'll talk a little bit about that later on, why that's a great opportunity for win-win collaborations. So this data is a snapshot to show how we really need to do a lot of stuff in the radiotherapy workforce. But I like this picture, because I think, coming out of, Black History Month in the United States as well, looking at what Martin Luther King talked about. I like this picture because it really captures the situation. We know what equality should look like. Everybody has the same level of chair to stand on. Equity, you may prop up the person who maybe need that. And really that's what most people when we're looking at, that's what you're looking at, trying to do. And then the reality is that, the person who is actually, most people who really need the help are actually in a hole. But what we really should aim for, and I think that's what Dr. King was talking about, is that we need to eliminate the barrier. Not just give people a higher chair who needed to stand on, but actually just take away the barrier. So no matter where you're born, wherever you are, you can have access. And so this is really the goal, of being able to think about how we can collaborate to eliminate these barriers. So just a couple of slides to talk about some of the history. As you know, there's a great opportunity with the Cancer Moonshot. When President Biden launched the Cancer Moonshot 2000, he reignited that in February 2022. There were really two key goals. One is to reduce mortality by 50% in 25 years, so by 2047. So which is kind of in line with the new statistics with WHO's growing cancer with 35 million new cases. The second goal was to increase the quality of life for those who are living with and surviving cancer in the meantime. And these are really ambitious goals, but they are, measurable. You can really target them. You can see how one could deliver that, come to those results. Just shortly after that, we launched the Lancet Oncology Commission for Sub-Saharan Africa. So these pictures, which I really commend, the Lancet Oncology for shining this light on Africa with David Collingridge. This was launched in Ghana. And then following that, we realized that, there's this tragic cancer case situation in Africa where there's going to be a doubling of the cancer incidence, 1 million deaths by 2030. So we actually reached out to the White House at that point. That was one of the key things where we said, okay, you really have to extend this cancer moonshot globally. And, some of the goals that we just talked about, reducing the death rates by 50% in 25 years, may actually be more achievable in low and middle income countries. And you can get wins from that. In fact, if you think about cervical cancer, you can actually eliminate it. We have the tools. We don't need new innovation. We just need implementation to do that. So at that time, President Biden was hosting the African leaders in Washington. We didn't get cancer on the president's agenda, but we were able to succeed to get this on the First Lady's agenda. So in this picture, you see Dr. Biden hosting 22 African First Ladies. Following that, the White House was able to make this announcement of over $350 million in public-private partnerships, towards extending the cancer moonshot to Africa. But I just want to show a couple of slides from why this is so important for Africa. It's a pandemic, cancer is really a pandemic. And, we know in Africa from the Lancet Commission that, the highest cancers are breast cancer. You see this picture from my friend Beatrice in Ghana. It's really shocking to show the situation there because 70% of the cases come late at a time when, you even need just palliative care. And you saw in that gap, in that map, you may not even have that because you don't have radiotherapy. But it's not just an issue of people dying. When we launched this in Nigeria, one of the key things that was even more prominent for the policymakers was the fact that there's an economic cost to this. So Nigeria lost about $5.6 billion in 2019 because of cancer. That was shocking for them. It was all over the news. That was not even the cancer death rates. It was the economic cost. We just came back from Tanzania with my friend Susie, and there one of the key things we highlighted with the Minister of Health was that, look, 1.2 billion was the cost. And they said it's more. The minister told me that it was more, that yes, that's true, but they know that it's more and that they really need to do something. So it was really wonderful to see the government take leadership there with the president of Zanzibar who joined us. And they're really looking towards, addressing this issue and collaborating internationally. In fact, it was an excellent example of how you can extend the cancer moonshot globally, where you have the government of Tanzania and the United States working together. But I just want to highlight this disparity one more. So one of my medical students went to Tanzania and was able to show that, the travel distances to an Ocean Road Cancer Institute, one of their main cancer centers, over 400 kilometers. It's just crazy. And so what are some of the solutions that we can do? One of the collaboration areas that we kind of started is really democratizing hyperfractionated radiation therapy. It can really, we already have an ongoing trial supported by BioVentures for Global Health, on prostate cancer, where you can show that it can increase access by over 400%, for prostate cancer. And then we're going on to breast and cervical cancer, major time and cost savings around this. And then, you can think about this. Actually, when you do hypofractionation, which just means you increase the radiation dose a little bit, but reduce the amount of time the patient has to come in. For example, for prostate cancer, there's already evidence that you can reduce the time from patient coming in 35 times to just coming in 7 times. So it means the time it takes to treat one patient, you can probably treat 5, right? So that's huge. But we're actually asking, in line with the cancer moonshot, to think bigger, right? So now you may have heard about flash radiotherapy, where it means that you can actually treat that patient in just one fraction. In less than a second, you can deliver radiation at ultra high dose rates with this. It's still currently in clinical trial, and I know that there are many clinical trials even in Europe around this. But, ARPA-H in the United States, which is one of the agencies, Advanced Research Projects Agency for Health that President Biden launched, is actually looking at a new program around this to be able to establish FLASH in collaboration with the world and extend the cancer moonshot globally. Now, this will also benefit United States. As we think about hashtag Biden Global Cancer Moonshot, we are really saying that if you invest into this, it will benefit United States, but also globally. So it's not just the humanitarian aid, developing such approaches can actually benefit United States as well. All right, so the Lancet Commission has really been helping lead the Lancet Oncology with David Collingridge has been leading a lot of things around this with the Lancet Commissions on radiotherapy. I just wanted to highlight that there's currently a Lancet Oncology Commission on the cancer moonshot, and this is going to include some of these recommendations on how there are many opportunities for us to collaborate globally. So in my last slide, I just want to mention the focus on collaboration, which Pat highlighted at the beginning. We really have to collaborate to close the cancer care gap. One of the policy after the $350 million highlighted by the White House in December 2022, we then said, well, that's a step in the right direction. But look, we need to think bigger, right? So the idea of a global cancer fund, which is not new completely, proposed that. And this is something that the White House has taken very seriously. And so again, in this, there are many countries, not just the White House. When we were at London Global Cancer Week, some of the meetings we had, we see that there was really interest from the side of the UK to get involved with this as well, including at the highest levels. And so it's great to see what, the Global Coalition for Radiotherapy with Pat, the championing so those initiatives along with Susie. And then coming back from Tanzania just yesterday, the government, obviously, there are many countries that are looking for this kind of leadership and would really be a way to mobilize the world to collaborate against these monster cancer statistics. And so it needs leadership and strategy. It has to be win-win. It has to be high impact. We should think about it as how it benefits not just low and middle-income countries, but also high-income countries. And I end by just saying that there are some really great opportunities. I highlight a couple of them here. Where I think, so the Lancet Commission, Oncology Commission on the Cancer Moonshot, it's actually really focusing on workforce, capacity building. I showed some of the numbers at the beginning where, you can make a big difference around that. And again, it should be bi-directional. We see that the benefits will be win-win. But low-hanging fruit is cervical cancer elimination we just talked about. If you can dedicate resources towards that, the cancer moonshot will also be met and exceeded. They will not only have the death rates, they'll eliminate cervical cancer. And then a great opportunity you may have heard Bill Gates and other people talking about is the opportunity with AI, where you can really help leapfrog, even lower middle-income countries around this. So we come today with the stunning statistics that we see from the World Health Organization. We're at an important time where, through global collaborations, we can really, really make a big difference. And as we go forward into the future, we look forward, hopefully, with hope in this year, that even something like the Global Cancer Fund can become a reality soon. And so as you go out, please, the White House is asking us to promote Global Cancer Moonshot hashtag, because I think that's part of the lead up to something big, hopefully. Thank you so much for your opportunity to speak to you today, and I'm looking forward to the questions and discussions afterwards.
Will, that's absolutely great and so exciting to share that with all those opportunities and solutions. And if anybody's got a burning question, do shout. Just one thing that came to mind is, how could we involve patient and patient advocate groups more, and will that really help?
It will help. They have to be the head part. You are absolutely right. So actually, in the last meeting we had at the White House, and I know Ted was also there, the key people who were championing this, we had patient advocates who were there. The message really has to be coming from them. And we have some, so you're thinking in the right way, that those are the people that, we need to really involve in these collaborations that you highlight, so the collaborations really has to include all stakeholders, and they should be at the forefront of this with us.
Yeah, no, well, fantastic. Well, everybody, do add your questions on, and we'll come back to this. Will, don't go away. Fantastic. Can I just introduce Ted now? Ted, I'm glad you could join us. So Ted also needs no introduction as a highlighter. So he's the founding director of the NCI's new Cancer for Global Health development of affordable cancer technology and national control plans and training, obviously a gynecology oncology background, and he's really spearheading the development of implementation science, and he's coming with some fantastic ideas today. So Ted, fire away for us.
Thank you very much. Can I have the next slide, please? So one of the things that we've been talking about is how we can build on the great work that the Global Coalition for Radiation Therapy has done with their development of essential standards to actually implement things to make sure that cancer patients around the world get the best possible medical imaging, radiation therapy, chemotherapy, chemoradiation. And so to do that, we need to make sure that we have the right people around the table. We've talked about the importance of advocacy groups, of patients and their families, the doctors, the nurses, the physicists, the technicians. We need industry at the table, the industry supporting cancer diagnosis, cancer imaging, radiation, chemotherapy. We need governments at the city, state, and national level. We need the International Atomic Energy Agency, the World Health Organization, the academic community, the medical professional societies, as well as representatives of the third-party payers and the people running the insurance programs to make sure that the insurance actually covers what is needed. And we need to have our colleagues in the global health community as well, because they are may not be as familiar with the needs of cancer patients, the needs for cancer treatment, but they have worked hard to improve global health for other health issues, and I think they can really help us think through what we need for cancer patients. So what do we need for the individual cancer patient? We know we need a timely cancer diagnosis with an accurate pathological diagnosis. We need a timely staging through medical imaging. And then we want to have that person presented, or the person's case presented at a multidisciplinary tumor board, so we can make plans for what is the optimal treatment regimen for that person. As I mentioned, we need insurance coverage because we know we have to be able to have a good way to pay for the hospital, the doctors, the nurses, the technicians, all the staff have to get their salaries. And where is that money going to come from? Part of that money needs to come from a universal health care or other insurance programs. We know, and certainly Will mentioned this, the importance of making sure that people can actually get to the treatment site on time to get started with their radiation. So we need to figure out how to do patient navigation, how to help assist with transportation, assist with lodging, and meals. And here we can learn from our colleagues in pediatric oncology who have really done this in low resource settings to build the residential hostels, to arrange for low-cost transportation, and to arrange for lodging. One of the things that we're excited about is some of the new work being done to use digital imaging data to help guide and the radiation treatment planning. That's something that can really be a savings in resources and time, and we need to look to see whether this will work in a variety of settings. We certainly have learned as well about how that we can do efficient, centralized treatment planning so that we can expand our delivery of radiation therapy in more rural locations and satellite locations, but not necessarily have to have people doing treatment planning in the more distant locations. We also know that we need to improve patient experience. All too often, people are told to show up at 7 in the morning to receive radiation, and they have to sit around until 3 o'clock in the afternoon before they actually get radiation. So we need to see how we can work with sites to improve patient flow so that people can have a limited amount of time that they actually need to be at the hospital getting their treatment. We've learned certainly that if we have good internet access, we can do real-time quality assurance, quality control for our treatment, and so we need to figure out how to do this routinely. We need to make sure that our patients complete their treatment in a timely manner, and that we have both short-term and long-term follow-up in place. And it's we can do this now with the use of mobile phones, so that we can stay in touch with patients, know how they're doing, identify any problems, treat symptoms. We also need to make sure that we have good survivorship care in place. As we treat more patients, we're going to be curing more patients. We need to help them get back to normal life, normal work. And so we really need to put an emphasis on survivorship as well as symptom management. Looking at the individual site requirements, we know we need to work with sites to make sure that we have a reliable source of electricity, a reliable source of internet access, that they have clean water, that they have the service contracts in place to get the machines fixed, that they have a supply chain in place for all the supplies they need. We need to make sure that we have trained technicians to repair machines, that we have a green channel to import parts, that we have money already earmarked to pay for replacement parts, so we don't have sites waiting 6 months to get waiting on a country's budget to be passed before they can actually find the money to buy the part and then bring that part in. We need to, I think, reach a consensus on what is acceptable in terms of time to get equipment fixed. We know these are the machines that we need to deliver radiation therapy are finicky. They often break down, but we need to be able to get them up and running again within 24 hours, 48 hours, 72 hours, so that people can continue to get their treatment in a timely way. And we need transparency and accountability. So we need to figure out how best to do that. As this slide makes clear, we need real-time metrics. We need collaboration across health domains. And we know that this needs to be recognized globally, and that we need to have the appropriate financial support so that these our services are sustainable. Next slide, please. So how are we going to do this? We envision convening planning meetings virtually and in person as we can line them up to identify the scopes, the objectives, the timelines of some of the things I've discussed and that Will has discussed before me. Where we have the opportunity for high-level workshops at high-profile events such as the World Health Assembly, such as the the yearly meetings in London on cancer, such as the UICC World Cancer Congress. We want to be able to use those high-level workshops to get people together. And we know the importance of establishing clear deliverables at each stage of the projects. So we don't just bring people together to talk, but to actually share best practices, identify what we need, and build on the good work that's been done so far by the Global Coalition for Radiation Therapy. Next slide, please. So outcomes, I think I've already alluded to them. We need to strengthen collaboration around the table. We need real-time metrics so that we know whether the machines are up and running. We know uptime, we know downtime, we know that which patients or how many patients are getting the appropriate dose and schedule of radiation within the appropriate time limit. We want to make sure that our colleagues in health and global health understand the importance of medical imaging and radiation. We need to work with funders to make sure that we have the appropriate financial support so that we can do this right. So we propose 2 virtual meetings, one in March and one in April, and then our in-person meeting as a satellite session at the upcoming World Health Assembly in Geneva in May. So I invite you to join us in this process, in this adventure, and we look forward to your comments, your thoughts, and your help with this exciting activity. Over to you, Pat.
Ted, thank you so much. And what I say, what an amazing initiative of yours. It's just what we need. So we've got to the stage, we've got the essentials documents, what we need, but this is really kicking on fast to the implementation now. How do we make this actually work? So just one quick question for me. What do you see as the biggest challenges and how can we engage stakeholders? Obviously, we'll need our imaging colleagues and other colleagues. What's your thinking there?
Well, I mean, I think we'll set out some of the challenges. We have to figure out how to make these services more accessible from a geographical perspective, from an economic perspective, how to make them sustainable. And I think we also want to make sure that we improve the patient experience and patient outcome. So I'll stop there.
Yeah, no, that's fantastic. Have we got any other questions from the floor on this? This is very exciting. While we're thinking, just another one for me, Ted, sorry to dominate here. Obviously, data sharing and data information is really important. Can you see some step changes there? What would be our pathway there to make some big different changes? Is it in terms of getting more standardization? What do you think?
Well, first, we need to work with countries to improve their health informatics systems so that you can track individual patients from time of diagnosis through treatment, through follow-up, so that you can link data from clinics to the medical record data at local hospitals, at central hospitals, at cancer centers. Right now, that's very hard to do. In the United States, we wrestle with this issue. Secondly, we need to improve, be able to exchange data easily from, the digital imaging from data to guide our treatment planning. I mean, that's an obvious way that we can save time and money.
No, great. Rolando, you have a question, and also Michelle in the chat. Yes, we'll get some invitations out. Rolando, tell us.
Okay. No, my question is simple. I think that we have all the tools. We have the key performance indicator. We have all the recommendations. We have the technical things. We have everything. But the problem is how to implement it. I think that there are 2 initiatives in this moment that are going around implementation, which is the Race of Hope in the IEA, and also in SICAN, they're working with the cities in the implementation side, which is the real problem, because knowing what to do, really, people is tired of hearing what to do. We know. Everybody knows. Many people knows. In the cities, in the world, in the countries, they know. But how? That's the problem. And that's why my question was. Thank you.
So Ted, you're thinking?
Well, I mean, I agree with Rolanda. We know what are the critical pieces, but we have to get people talking together to make sure that we that the pieces fit together. I mean, I've certainly talked to Bay and Lisa at the Rays of Hope program. It's exciting, but we've said we have to build in the day-to-day metrics. What's the uptime? What's the downtime? What's how do we get those machines that are currently installed but are not working? How do we get them working? And I love the opportunity to build on the experience of the Cancer City Challenge, because they've really looked at the system across all aspects, all the domains of cancer care, to make sure that things are working. So part of what Rolando, to answer your question, we don't need to reinvent the wheel. We have to look at examples that are working well, and then figure out how to replicate those in other countries and in other situations.
Well, really very exciting. And I know, Ted, with your dynamism, we'll get there, but it's all about granularity and just moving through this and getting there. Any more questions, do add. We always come to that and back. Ted, thanks ever so much then. Can I just move on now to Susie Stanway, again, who needs no introduction, from the London Global Cancer Week. She's a clinician herself, working at the Marsden, specialising in breast cancer, and she co-established and co-organises the London Global Cancer Week. Also, she co-founded the UK and Ireland Global Cancer Network, and she teaches and works hugely internationally. So it's an absolute pleasure, Susie, for you to share your thinking with us today.
Oh, thank you very much, Pat. Thanks, Darian. Thanks, GCR.
London Global Cancer Week started in 2016 and has since, under the direction of Mark Lodge in 2019, become a whole week of meetings. And it really tries to give a 360-degree picture of the rising challenge of cancer, particularly focusing on low and middle income countries, so that people can share experiences, discuss solutions, just help develop more motion and how we're going to improve the situation. So I'm going to just give a little bit of a preamble of some of the conversations that we had at a round table during London Global Cancer Week last year that Mark Lodge convened. And then I will end with the 12 points that we came up with that we thought were important when it comes to thinking about resilience in cancer systems. So just some definitions, just to make it clear. So the Oxford definition for resilience is really all about ability to bounce back, but it's a little bit more complicated than that. So it's the ability of a system, community, or society exposed to hazards to resist, absorb, adapt to, transform, and recover from effects of a hazard in a timely and efficient manner through preservation and restoration of essential basic structures and functions. And when we talk about health systems, we're talking about all the activities whose primary purpose is to promote, restore, or maintain health. Next slide, please. So resilient to what? Well, a variety of shocks that can be acute, chronic, acute on chronic, and we're seeing huge numbers of these shocks at the moment, so it's really timely. So economic turbulence, we're in an economical turbulent time at the moment. Advanced economies are slowing, inflation is at a multi-decades high in many countries, many of the central banks have pivoted towards higher interest rates, and global debt is at an all-time high, staggering amount. I think it's over 300 trillion US dollars. And also factored into this is huge inequalities within countries and between countries, which must be taken into consideration when trying to build resilience. Shocking statistics like the world's richest 22 men have more money than all the 350 million women in Africa. Just horrendous statistics. Resistant to pandemics, we'll come on to COVID in a second, resistant to conflict affecting so many countries at the moment, climate change events and natural disasters. Next slide, please. So what's needed? Well, I've put at the top national security, because I think without that, healthcare is challenging enough to deliver. It's hard enough to deliver evidence-based cancer care across the continuum to all in an efficient way. But factor in conflict and that this becomes even more difficult. And it's of no coincidence that the WHO theme the year before last was health for peace and peace for health. You also need political will. This affects all of government, and we need to have money for universal health coverage so that all individuals and communities have got access to healthcare across the continuum without suffering financial hardship. And we need to have civil society activation with multi-sectoral collaborations. Next slide, please. So there have been various useful documents produced. So as a result of COVID, which has exposed weaknesses in all of our health systems, but has also posed an opportunity to improve things. The WHO produced this document, Building Health Systems Resilience for UHC and Health Security During the COVID-19 Pandemic and Beyond. And really, I think that the emphasis is on that these solutions need to be contextualized for different regions. And for example, this is one that the Eastern Mediterranean region produced with various points. But investment in preparedness offers significant returns. So that needs to feature when you're developing your national cancer control plan. Next slide, please. So that was all about sort of healthcare learnings during COVID, and those have been well documented. But also, what did we learn about cancer care during COVID? So huge numbers of people, I think it was 6 million people around the world died from COVID, but also there were vast numbers of avoidable cancer deaths that very sadly happened. And what can we learn from that so this doesn't happen again? And this is a cross-country study which looked at global health system resilience during encounters with stressors, lessons learned from cancer services during COVID-19 pandemic. And although there were no sort of universal adaptive strategies that were applicable to all systems, there were some common issues identified, such as lack of contingency plans for pandemics, inadequate financial policies for cancer patients, lack of approaches for competing priorities of cancer care and pandemic control. So next slide, please. So this roundtable, we looked at what was important. There was huge discussions around national cancer control plans, of course. As Antoine Saint-Exupéry said, a goal without a plan is just a wish. So we need to have proper plans. These have to be political decisions. They have to be accountable. They have to be equal, fair, acceptable, affordable, have multidisciplinary input, be reportable, etc. They need to feature information about cancer intelligence. We need to know what the survival rates are, prevalence, incidence at a minimum. And we need to make sure that research capacity is invested in and that high quality implementation science is done in countries so that different regions, different countries can develop their own research base. And knowledge, attitudes, beliefs and behaviours need to be considered as well. Getting the right narrative out for different areas that empowers patients. Next slide, please. So intellectuals solve problems and geniuses prevent them, Albert Einstein said. Next slide, please. And I think that this is really pertinent with cervical cancer. So we know how important prevention, screening, early diagnosis is. Cervical cancer, entirely preventable, should be eliminated. We all know the WHO cervical cancer elimination initiative and about that. But also this early presentation, early diagnosis, early treatment is all about awareness, screening and education. Will and I have just come back from Tanzania this morning. We were at Ocean Road, fantastic cancer centre there. 75% of their inpatients are women, 33% of their outpatients is around cervical cancer. And I think if we're going to have a global fund for cancer, cervical cancer eradication has got to feature really, really highly in there. Next slide, please. The economic case. So we as a cancer community have got to present a compelling narrative that investing, this is an investment, not a cost. We've got the data out there that shows this. This is an example of a paper published by Richard Sullivan, 2015, showing the cumulative GDP loss if you don't invest in cancer surgery, for example. At the bottom, we've got Danielle Rodin's paper from Canada and her team, showing that radiotherapy is an integral part and produces strong return on investment when countries invest in it. So we've got the data, we've just got to get it out there to finance ministers. Next slide, please. Investing in workforce, hugely important. So 57 countries with critical workforce shortages, 2.4 million doctors, nurses, midwives needed. 24% of the global cancer burden is in, where there isn't the proper workforce. And we need to have a consistent approach to improve that. Or can you just go back just for 2 seconds? Thank you. I just wanted to highlight this study that Werner van der Pui and her colleagues did about cancer workforce in Africa, prospectus from a global survey that was distributed by Aortic in, I think it was in 10 countries across Africa, just showing the higher workload that colleagues in Africa have and the lower job satisfaction, and much of this probably related to the workforce problem. So we need to make sure that gets into cancer control plans as well. Next slide, please. I've put here lessons learnt during COVID. During times of conflict. This needs to feature as well in cancer control plans. I've put here some papers from Nazik Hamad, who has tirelessly campaigned and tried to raise the profile of what's happening in Sudan. We know that 2 billion people in the world live in countries in conflict. There are over 100 million displaced people in the world. On the right is some work that Horia Vortes recently published in the Lancet Oncology, showing humanitarian work around cancer care done in Moldova and Romania that he's done with Blue Heron Foundation. And there are lessons to be learned from this. Clearly, no conflict is the same as another, but things like awareness raising through diaspora, decentralization of services, establishing safe corridors for medications to get in, we know are hugely important and we can learn from. Next slide, please. The climate crisis. This is in The Guardian 2 days ago. We just had the world's, the hottest year ever. It was great to hear Ajay Banga 2 days ago discussing his first 8 months as president of the World Bank and saying how he's going to increase climate financing to 45% of what the bank gives. This is just so important. Next slide, please. We know that climate change and what's happening is bad for cancer. There's increased environmental carcinogens, difficulty accessing care. And we know that cancer care, if we don't take this on board, can be bad for the environment. And that we as a community, it's incumbent upon us to think about how we can do things better. This is a paper that was published in the Journal of Cancer Policy, which looks at both sides of that argument. Fabulous oncologist Joe Schiller in the US and Virginia has set up this group called OUCH. It's the, I think, only cancer and climate not-for-profit organization. Oncology Unites for Climate Health. And she has got lofty ambitions for how she wants to unite the cancer community to play our part in this agenda. Next slide, please. Women have to feature at the table heavily when we're talking about cancer control planning and developing resilience. This is, of course, a Vera Ginsburg commission that she published last year, Women, Power and Cancer. Cancer is in the top 3 causes of premature mortality amongst women in almost all countries in the world. 1.5 million deaths in women who die prematurely from cancer, which could be averted by primary prevention or early detection. And women are more likely than men to have to lack knowledge, undergo financial catastrophe as a result of a cancer diagnosis, and be underrepresented as leaders. And they give a disproportionate amount of the care as well. Next slide, please. So in summary, and I thank Mark Lodge for summarising everybody's contributions during this roundtable, we felt that from a policy perspective, cancer should be made a notifiable disease. Through legislation, NCCP should be elevated to the status of law, and that we really need to rigorously pursue the goal of universal health coverage as the best way of delivering evidence-based effective cancer care across the continuum so people don't suffer financial hardship. From a governance and leadership perspective, cancer control is an all-of-government issue, and it can be a national development indicator and should be set within the purview of the President or the Prime Minister. It's that important. Establish a multi-sectoral, all-of-society consensus to formulate and sustain national cancer control plans that sets goals beyond political short-term limits. And prepare for crises. This has to feature in the cancer plans. This was brought up at the World Cancer Leaders Summit at the UICC meeting last year, and is increasingly gaining momentum that it's important that it should feature in NCCPs. And we need to reduce the siloing of these issues within different issue communities. So issues such as antimicrobial resistance, tobacco control, sugar, climate, pollution, these are all interrelated. Many of them have got commonalities in how they're formed, and there are shared health system solutions here as well. And around implementation, we need to encourage engagement with the public and the private sectors, ensure that NCCPs include regulations for governance, monitoring and evaluation, work with civil society actors to educate populations about cancer, and address the huge shortfall of trained workforce, and think of better, more cleverer ways of working. And inter-country collaboration is vital. Thank you very much for letting me speak. And yeah, London Global Cancer Week this year, 10th to the 15th of November. Please work with us. Please come. We'd love more hosts.
Great. Susie, thank you. Perhaps if you could take questions in the chat, because we're well behind time on that now. But Susie, great, fantastic data, all evidence-based and on-the-ground data. So I'll just scrunch my time down into 2 minutes now. So we can move on. We know who I am. I'm an oncologist. Yeah. So I just want to update us on the essentials documents. Remember, we've all worked really hard in the GCR on this to try and produce what would be an essential for radiotherapy and national control plan. So we've had workshops, and just going over these here, the training and technical support, the quality and safety, the maintenance and service, Darren, the next one, the advocacy and the data monitoring. So that's people who work very hard. We've got together the plans. They're up online now. We did a soft launch in Global Cancer Week, and now this is our official launch here, as it were. And we want to keep this as a live document. We want to have people engaged here. We want to have contributors here. We've got the contributors laid out here from the different countries. You can see South America's missing and other countries are missing. So please do have some feedback to us. We are obviously moving things on. So Darian, the next one. There are things we're trying now to actually have individual countries develop things. I know Tim Haller is working very hard with 03 American Association of Physicians in Medicine about the data. And so we hope we will then be able to have examples where we can introduce these plans and then iterate back and learn more from each other and then implement them more, again with Ted's plan here. I'm going to introduce Sarah in a moment, who's got the UK experience, but so far we're piloting these in UK, Sweden and Ghana and Indonesia, and hopefully we'll learn a lot from that. So really it's just a call to the community now of do read through. I know so many of you have worked so hard on that. Let's get the feedback, see how we can actually implement these as plans, and then move forward with the collaboration with Ted and others to move this into an implementation phase and really get where we need to be with radiation oncology. So I know that was really fast, but I needed to catch up. And so that's where we are now. And so I just want to introduce, as an example of working on these, where we can go next in countries, I want to introduce Sarah Quinlan, who is our Director of Radiotherapy UK, an advocate for patients and radiotherapy, and was already awarded her MBE for her work in heart services before. So without any ado, to not take your time, Sarah, fire away and tell us about the UK vision document.
Great. Thank you so much, Pat, and thank you for having me today. It's really interesting because we're talking about this global and the essential standards, and then in parallel with the essential standards, we've been working on kind of the national plan about what world-class radiotherapy in the UK would look like. And really it's come about because what's happening in the UK in the minute is that we have nearly 4 in 10 cancer patients waiting too long for their treatment. We have an estimated increase for cancer patients in the UK up to 500,000. That's an increase of a third by 2040. And within radiotherapy, access to radiotherapy in the UK sits at about 27%, and the international standards say that should be about 53%. So although we do have really good, high quality radiotherapy available in the UK, we are lagging behind comparable countries. And that also shows in where we sit in terms of the international cancer survival tables. So what happened really, how this document came about and how this piece of work came about, was that we as a charity are secretariat to the APPG for radiotherapy. And this sits really closely with the group that I had chaired within the Essential Standards, which was the advocacy group, because it's all about advocating. It's all about finding out the avenues where we can influence and where we can get the patient voice to the decision makers. And that group is a cross-party group of parliamentarians who are all keen to see increased investment in radiotherapy to improve cancer services for their constituents. And the APPG had held a number of inquiries into cancer services in the UK and radiotherapy provision, and consistently noting the lack of long-term planning and the lack of leadership within that. And then last summer, they asked us to facilitate a vision for radiotherapy to show what can be achieved over the next decade to transform radiotherapy services and essentially to improve how long and how well patients live. So our approach to this was very much collaboration from the start. And any vision that we would develop about radiotherapy needs to involve the radiotherapy community, and it needs to involve radiotherapy patients. And that was at the heart of our approach. We undertook patient surveys, worked with our patient engagement group, frontline workforce surveys, and met with charities, the workforce, industry, professional organizations, experts, and academics. And what we were asking them was, well, what does world-class radiotherapy look like for you? And then how do we get there? We used the publicly available data to draw evidence and comparisons with what was happening currently. So we pulled together all these contributions, and I have to highlight here our co-authors, Dr. Katie Wakeham, who's a clinical oncologist in London, and Tim Cooper, who's an advisor within radiotherapy, and he has worked previously in 2009 plans like this. So a lot of experience in terms of the policy and the understanding of how we influence and what we need to be presenting as well. And ultimately what we wanted to do was create a patient-centered vision that set out a realistic but ultimately ambitious way forward to transform radiotherapy services. So if we could just move on to the next slide, please. So we actually launched the document on Tuesday past there. So this is a very timely webinar for that. And at the launch, we brought together the radiotherapy community and patients. This bottom picture here of the 4 people in front of the radiotherapy sign is actually, they're all patients who came and spoke about the impact that access to radiotherapy had for them. And we brought everybody together to meet with MPs in Parliament to speak to this report and the importance of implementing it. And it was a really successful event. Again, core to what we do, we had patient voice at the heart of the event. And if we could just go to the next slide, please, Darian. So what does the document say? I've just brought up the executive summary, but the idea is right patient, right treatment, right time. And it sets out 6 key areas of action. And I think for everybody who's in this room, these will be familiar areas that we need action in. They are leadership, access, workforce, data, research, and investment. And within this, we outlined what the challenges are. So those challenges are UK, but I would say that they're not unique to the UK in many ways. We also set out what we thought world class looked like within that, and then what the next steps need to happen to achieve that. And ultimately, we highlight the need for a UK-wide national plan for radiotherapy that is supported by the 4 nations and informs long-term planning and long-term investment. A very brief overview of it. We do set out the need for fair and timely access to treatment, and within that, really strongly coming through from patients in the UK is the need for improved late effect services as well. We highlight the current pressures that are being experienced by the workforce and how a relatively small and planned investment could create a really sustainable and flexible workforce that can harness the advances in healthcare systems. And we also highlight, just with Ted talking about it earlier on, the need for a single data source within the UK that links analysis from other systems to drive improvements in patient outcomes. And this really struck me, the need for actionable data. We have quite a lot of data within radiotherapy, but we need to take this real-time metrics and make them actionable to drive improvement. We also highlight the need for an integrated radiotherapy strategy, and ultimately, the only way we can achieve this is through long-term transformative investment. So we are making the case within this document for long-term transformative investment and what that could lead to for patients. Thank you, Darian. Move the next slide. Thank you. So for us, this isn't about creating a document that then sits on a shelf. The aim of this is to continue to drive forward a collaborative approach within the radiotherapy community within the UK to drive forward discussions. We have a general election coming up in a few months' time, and this is a blueprint for manifestos or for a new sitting government or a current sitting government to take and understand how they can transform cancer services in the UK. And I suppose as a charity as well, we're really aware that this is something we need to stay on top of too. So we've undertaken a commitment to review and chart the progress of it on an annual basis or whenever new innovations come through, so that this document reflects what's happening. So the vision, it sets out how we get to world-class radiotherapy by 2034. But again, to reflect some of the conversations we're having today, it's in the hands of politicians and decision makers and leaders in healthcare to actually implement this. But I suppose what I would say is that it's in the power of all of us to collaborate, raise awareness, and advocate for radiotherapy and to advocate for the patients. Thank you.
Just got time for one or two questions, and we can also loop Susie back in there. What I was really struck by was the importance of the patients to get them involved, the importance of the political, and Susie, that speaks to your point about, I love the fact of getting in law, we should have a national cancer control plan. We could start in England, that would be good. And I think also, as in fact, Ben Lee from Writers Counter Cancer emailed me this morning, thinking about really promotion and advocacy via celebrities. Sarah's document, they may not have seen it. We have Brian Robson there, who is advocating, and actually, I know he's English, but he's Man United. A lot of people, ex-captain of England. You know, it's a way of somehow wrapping up all we need to do in making more noise, more advocacy. I know in the UK, we've now had our king with his diagnosis of cancer, and that's started some really useful conversations actually over the last few days. So I think there's a lot we can do with extending this, how we communicate. I don't know whether Susie or Sarah, you wanted to say something about that. We've got a minute, sorry.
Yeah, well, the very shameless plug I suppose I have about that, Pat, is that, you know, the use of things like music and sport to cross geopolitical boundaries and to get these kind of messages out. So yeah, last year we recorded a song to raise awareness for people with cancer in areas of war, focusing on Sudan and Ukraine. So I guess that's an example of what you've just said.
Yeah, I want to continue. Yeah, good. Any Sarah, any last comments from yourself?
Well, no, I suppose it's just the global nature of cancer. You know, it's going to affect everybody, and I think that whenever celebrities do talk about it openly, or for example, the King's having an open conversation about it, it just allows everybody else to start thinking about it and taking action. So it's helpful. It's very, very helpful.
Good. Okay, well, I'll just go to the last slide now. I really want to thank absolutely everybody for such a contribution and being so helpful. So next stages in terms of the essentials document, what the GCR is doing, there is a workshop on the 27th of February that we're going to be talking about the next stage with the essential document. We'll be also sending out information about the new initiative with it that's Ted's leading with us on the implementation. And obviously any ideas and any links. It was hugely important today that we raise such issues and try and raise radiotherapy up in the agenda. So I think we'll leave it now. And I know people have got very busy days, but I can't thank you enough. This is all being recorded. We'll send things out and we're making great progress. So thank you hugely and have a good rest of the day.